I'd like to get into that. So let's go ahead and get started. Slide number 55. Okay. Nope, you got to go all the way down. This is in the beginning. Keep going all the way down. All the way. Keep going. Keep going. Keep going.
Morning, Dr. Chandrasekhar.
Good morning. Keep going. Shashi, you're wearing a mask.
Yeah, I just came back from. So I moved it now.
Oh, that's right. Now
It's mandatory, isn't it?
yeah, the Karnataka government has mandated it. Yeah.
Yes, yes.
Okay. All right. So transfusion therapy. Let's go next slide. Okay. So in this hour, what we're going to talk about is we're going to start defining blood product use. What are the criteria for red cell transfusion? What are the indications for platelet and plasma transfusion? And we're going to talk about the risks of infection and other risks associated with transfusions. So we'll go through this. Next slide. Okay. The general principles are that, we typically with blood banking, when blood banking capacity is there, we don't use whole blood. The one exception may be road traffic accidents. And even in the United States, we've been going to using the equivalent of whole blood, which, in massive transfusion protocols. By the way, Shashi, I sent you guys a copy of our massive transfusion protocol sheet. So you may want to look at that. That includes TXA. We use tranexamic acid early on in road traffic accident patients. If it's within 3 hours, you can go ahead and use TXA. It does reduce the amount of oozing that is present. So in these patients, and even perioperatively for both general surgical and other vascular cases, general surgical cases, orthopedic cases, and cardiac surgical cases. Tranexamic acid has been very useful. It's a terrific drug. You should be considering it. If your team on the ground hasn't considered it, introduce it to them because it's going to be very important. Okay. But that having been said, as far as transfusions of our patients are concerned, we use component therapy as needed. So we don't necessarily give whole blood. We give the various different components as needed. Now, please understand also that we don't just dump blood products into patients with one exception, maybe the massive transfusion protocol. When you have the massive transfusion protocol in play, then you can give whatever blood products you feel are appropriate for the patient. But outside of that, if you feel that you need, let's say, packed red cells, you have to describe what your indication is. So if you're requesting transfusion, please, in your note, document why, so that we can make sure that there's indication for this. And if you're saying it's oxygen transport, really speaking, you can allow the hemoglobin to drift down to 7. Liberal transfusion policies have never been shown to improve outcomes, even in septic patients. We'll talk about the exceptions in a little bit, but there's very few exceptions to that rule, but there are some, and we'll talk about those. Next slide. Okay, whole blood, rarely ever used. But if you are giving whole blood, remember the citrate that you're providing is going to alkalinize your patient so that you will develop a metabolic. If you give lots of whole blood, you will develop a metabolic alkalosis. And with the alkalosis being present, the patient's ability to, at the cellular level, to take oxygen off is going to be limited. Even though the saturations may be good on the hemoglobin, the ability to use oxygen at the cellular level may be impaired. So that's something to keep in mind. The other thing is if they go alkaline, the other thing is ionized calcium levels will drop. So you have to keep that in mind. So keep that in mind, please. Next slide. Okay. When we give packed red cells, it's all the red cells in a unit of blood, but the hematocrit for the packed red cells is 70%. But again, please keep in mind that if you're giving packed red blood cells, it's a short-term gain. We're not talking about, they're not going to last for 12 days like a normal 12 or, even, longer than that in a normal setting. These red cells, by, you may end up having to retransfuse the patient at least a couple of units by a couple of weeks. So you're really talking about short-term use of this. So if you're giving packed red cells to your patient, don't think that the hemoglobin level is going to elevate and stay elevated for extended periods of time. It's a short thing, and the storage time also plays into it because oftentimes these packed cells are stored in the fridge for a few days, so you got to keep that in mind. The other thing to keep in mind is oftentimes if there's prolonged storage, these packed red cell packets may have a little bit more potassium in them because the red cells are leaking out potassium, and you have to be a little careful in watching the potassium level in these patients. So be careful about that. Next slide. We do, the International Red Cross does freeze red cells every once in a while, and they'll use those frozen cells. Now, once you thaw it, you have to use it. You can't, there's not much you can do with it. Now, we do wash sometimes these red cells with saline to reduce that potassium level and stuff. Blood banks do this on a routine basis. So you may want to know especially if the storage time has been prolonged, the blood bank may tell you, watch the potassium level, doc, because the potassium level in that packet that you're transfusing may be slightly elevated. So next slide. Especially if you're dealing with patients with acute kidney injury, you may have to be a little bit more careful because they may not be able to handle that extra potassium load. So you have to keep that in mind. Okay, fresh frozen plasma. Fresh frozen plasma works really well in replacing factors, clotting factors. But you have to remember that if you want to give fibrinogen or factor VIII von Willebrands, it's not going to have enough of it. So if you want to replace fibrinogen in a patient that's fibrinogen deficient related to DIC or anything of that nature, then what you have to understand is you need to give the patient cryo. You can't give enough FFP. It's just too much volume that you have to provide. So keep that in mind. The other thing is that if you need factor VIII, again, factor VIII concentrate or cryoprecipitate is your answer. So that's something to keep in mind. Next slide. And platelets. Now, platelets, remember, if you're using pooled platelets, most places right now are not. They're using pherese platelets. Now, pherese platelets, 1 unit is equal to 6 units of pooled platelets. And the way to remember it is if I give one unit or 6 units of pooled platelets, I'm giving about 36,000 platelets to their count. I should be adding about 36,000 platelets to that count. With packed red cells, if you give 1 unit of packed red cells, you expect to see one gram rise in the hemoglobin. So or the equivalent, which is hematocrit going up by about 3%. So that's what you're really looking at. So again, please keep that in mind. How much are you expecting it to go up? And check to see if it is going up by that amount. If it's not, then you got to ask the question, what happened? So if you transfuse platelets and nothing happened to the platelet count, that means it's being swept up by the spleen or whatever. So you have to keep that in mind. Now, the surgeon is going to ask for platelets to be given, but you have to kind of remind the surgical team, please don't give the platelets until the surgeon is ready to take out that spleen and that spleen has been cross-clamped. So that, or the spleen is already out. Once the spleen is already out, then certainly for ITP and stuff, if you give platelets, it's okay. But you don't want to give platelets before that spleen is out, because if you give it, those platelets are simply going to be wasted. So you have to be careful. Now, if you're facing a heparin-induced thrombocytopenia, giving platelets may not be such a great idea. Now, sometimes you're stuck between a rock and a rock. What do I mean by this? You may be at a point where your platelet count is well below 20,000, and it may be down in the range of about 10,000, and you're worried about spontaneous bleeding in the brain, in addition to a thrombophilic state that's already there. So you're between a rock and a rock. At that juncture, you may have to give 1 or 2 units of platelets, but be careful about giving that in heparin-induced thrombocytopenia cases. The thrombocytopenia is not your problem. It's a thrombophilic state. What's happening is clots are being set off inadvertently throughout the vascular tree, and that's the problem with heparin-induced thrombocytopenia. And we'll talk about that in just a couple of minutes. Next slide. Okay, granulocytes we don't typically give. We give GM-CSF or GCSF. These are trade names are Neupogen. So I'm sure you guys have seen this. We don't transfuse granulocytes anymore. Next slide. Okay, so what are the indications of transfusion? Next slide. And you have to understand again what your indications are, because surgeons will ask you to transfuse patients just because, oh, the hemoglobin is 8. Oh, we'd like a little bit more oxygen carrying capacity, doctor. What you have to remind them is, the rest of the team is that there's really no data to substantiate willy-nilly transfusing. Now, if the patient has signs or symptoms of tissue hypoxia, like angina, confusion, EKG changes, they're leaking troponins, that is your indication to go ahead and transfuse and get the hemoglobin over 10. That I agree. But the transfusion trigger of 10 has gone away a long time ago. Don't go by that. Transfusion trigger should not be used. And again, hemoglobin of 7, yes. Once you get below hemoglobin of 7, that's a problem. Okay, that affects wound healing. That affects a lot of things in surgical patients. So at that point, you can say, okay, I don't want to go there. I have to fix it at that point. But if the patient, the other thing is if you transfuse the patient and they were having chest pain, what you need to document is, once you've transfused, has the chest pain gone away? Has the troponin leakage gone away? So you need to document whether your therapy has corrected the intrinsic problem or not. So don't just leave it at that. We transfused, yes, but did it correct the indication for transfusion is a question you have to be able to answer. So again, please remember that. Next slide. And again, if the extraction of oxygen off each hemoglobin is so great that you're not delivering enough oxygen that way, perhaps you do need to give a little bit more packed red cells in that setting. But you need to document that, and you need to document the correction after transfusion. Next slide. Okay, so you got a 65-year-old male that's involved in a motor vehicle crash, road traffic accident, and is noted to have elevated troponins. And this is a fairly common scenario, no? His hemoglobin is noted to be 8. His EKG shows no major ST segment changes. Patient vital signs are pretty reasonable. The next most appropriate step in the patient is, okay, so do you observe? Well, the problem is the patient is leaking troponins. So what are you going to do? Well, this is your indication for having a hemoglobin raised up to a hemoglobin of 10, right? So you're going to transfuse 2 units of packed red cells. And for those of you that recall your board examinations, this is actually straight out of the critical care boards, actually. This is an exact word for word, pretty much question that I got on my critical care board. So this is something that, classic indication in that this is a patient that's showing leaking of troponins. You need to transfuse the patient, get this hemoglobin over 10. So that's important. So again, you got to think about it that way. Next slide. Okay, so again, with platelet transfusion, talk to your surgeon. If they're going to undergo a procedure, your surgeon has to decide what level they want the platelet count at. Don't leave it, because the problem is if the surgeon encounters bleeding at surgery, the first person he's going to blame is you, because oh, the platelet count was low, that's why the patient is bleeding. You got to be very careful here. So that discussion, that point has to be discussed in the discussion before surgery, so that the surgeon is completely aware and everybody's on the same page. And you want to make sure that that discussion is there. Okay, next slide. Okay, fresh frozen plasma. It sounds kind of obvious, but if the patient is cold, your coagulation studies are going to be normal, okay? But the patient may be oozing, okay? You don't want to give FFP because the patient is cold. You want to give FFP if there is a diminution of coagulation products, right? So if the patient is oozing because they're cold, warm them up. Again, one of the things with surgical patients, and we'll talk about this again when we talk about damage control, but the lethal triad, you guys have to keep in mind. The lethal triad is hypothermia, acidosis, and hyperkalemia, and you really have to, and coagulopathy. So you're going to be seeing these things over and over again. You have to watch these patients like a hawk. If they're cold, warm them up, get them warmed up. And when you're giving fluids, here's the other thing about fluids. We hang fluids at room temperature. In trauma patients or post-surgical patients, the temperature, the core temperature can drop so quickly because of 2 reasons. One, the fluid you're giving is room temperature, is not body temperature, it's cold, right? If it's uncomfortably hot for the team in that resuscitation bay or in the recovery room or in the ICU, then the fluid in the ambient air is closer to body temperature. But for the most part, unless you're going through a blood warmer or some form of a warmer, it's not good. You want to make sure that you're giving, and especially blood, because blood has been stored in the fridge. And how often do we see cold blood being pumped into the patient, right? So again, and because the patient is already oozing, what's going to happen is the core temperature will fall even more. So this is something you really have to watch, the core temperature, especially in the immediate postoperative periods. The core temperature really takes a hit. So you have to keep tabs on that. And especially if the patient's oozing, the first question out of your mouth is the patient cold? Are they coagulopathic? Are they acidemic? Check. Make sure that you know what's going on. Why are they oozing? Next slide. Cryoprecipitate, very useful in hypofibrinogenemia, and certainly with hemophilia A, which is factor VIII Willebrand's deficiency, right? So again, very useful in those settings. Next slide. Okay, let's go over the hazards of blood product administration. Next slide. Okay, this is another classic situation that can happen in your hospital. Remember, we type in cross-match with ABO and RH, right? That's the major cross-match. If the major cross-match got screwed up somehow, let's say you gave the wrong blood to the wrong patient, okay? The patient will go hypotensive, and what you need to do is stop the transfusion and then come back and support the patient and send that blood back to blood bank so that they can do their workup. They have a whole slew of tests that they have to do. They will do that. You don't have to do any of that, but you got to make sure that that blood is sent back to blood bank so that they can check it out. Next slide. And again, if it's ABO incompatibility, let's say, number one, stop the offending transfusion. Supportive care only. There is no role, please remember, no role for steroids, no role for antihistamines, no role for heparin. Okay, so please remember that, because this is a classic scenario. It happens. Even in the best of ICUs, it happens. This is why we have two people checking whether it's the right patient, whether it's the right blood, over and over again, making sure that we're giving the right blood to the right patient. And believe it or not, even with all those precautions, it still happens that, when there's when a patient is crashing and we're getting blood up, it happens. So again, something to keep in mind. Next slide. And delayed transfusion reactions also occur. This is the reason why if a patient is febrile, your nurses should tell you, hey, we don't want to transfuse the patient because the patient is febrile. Get them out of the febrile state, because one of the first responses to a delayed transfusion reaction is fever. So if a fever develops during, and believe it or not, even in the US, with with all the blood banking capacity and all that we have, this was about a year and a half ago. We had a patient that developed a fever while being transfused. We went through the protocol, sent the blood back down to the blood bank, and guess what we got called back for? They cultured the blood and they gram stained it, and it turned out that there was, it grew out a Yersinia, a gram-negative, Yersinia. Who would have thought, in 2021 that, we would see a Yersinia infection? But you can. And this is the reason why all these protocols are there. So please make sure you send it back down to blood bank and make sure that they go through their tests. Next slide. Okay, so a 62-year-old male transfused 1 unit of packed red cells, and during the transfusion is noted to have become hypotensive and tachycardic. Stop the transfusion, right? Workup reveals the wrong blood type was given to the patient. Next most appropriate step in the management of the patient is continue the transfusion? No. Stop the transfusion? Yes. Start steroids? No. Start heparin? No. Just supportive care, okay? That's all you need to do, and that's what's important. Next slide. Okay. You will have sometimes where when you're transfusing somebody on a chronic basis that you're giving transfusions, sure, what evidence for not giving, because it didn't help. In fact, we looked at a whole bunch of transfusion reactions. This was in the 80s and 1990s. And lots of studies were done on whether we give steroids, whether we give antihistamines, and all those studies essentially showed that there was no benefit, and perhaps there was detrimental issue related to giving high dose steroids in those patients. That's why we stopped doing it. But unfortunately, what happened is that this information doesn't get disseminated downstream, and that's the problem, unfortunately. So again, that's something to keep in mind. This was old data, but it's really solid data that was there, that was studied. So this was good prospective randomized studies and large retrospective analyses as well that showed that this doesn't help. Okay, so with regard to patients being transfused and getting rashes and stuff and fever and LFT elevation after transfusion, what we found was that when we transfuse red cells, we don't transfuse just red cells. We transfuse red cells and white blood cells along with the red blood cells. And because of that, those white blood cells that we're transfusing may turn around and attack the recipient as foreign. So what happens here is that it's a graft, which is the transfused blood versus host reaction. And the thing is these are immunodeficient patients. And by the way, if the patient is not a transplant patient and they're showing you graft versus host type of rash and so forth, what you really have to think in terms of is, are they HIV? Here's the other lesson that you have to think in terms of. If you're seeing something where a severe immunodeficient patient should demonstrate something, look for HIV, okay? The example I can give you is we had a sudden increase in the number of tuberculosis patients in Brooklyn, in the borough of Brooklyn. And we couldn't explain why, so we started checking everybody for HIV. And it turned out that HIV levels, HIV patients, they were contracting HIV, and that's why the TB rates went up. So you have to understand, anytime you see something, please look for an explanation. If somebody's reacting like they're immunodeficient, ask the question, why is he behaving like an immunodeficient patient? So that's something to keep in mind. Next slide. Okay, Hep B screen, wonderful. Hep C screen, wonderful, okay? AIDS, they'll ask you the question when you're transfusing. It's about 1 in 2 million, okay, transfusions that you can get AIDS from that, okay? CMV is an interesting problem. Now, CMV should not pose an issue to a normal immunocompetent individual being transfused. But if they develop a CMV infection after transfusion, you got to ask the question, how are they immunodeficient? Are they HIV? Are they on immunosuppressants? What's going on and why? Because we don't typically screen blood products for CMV, and CMV can be passed along. So it's something that you got to keep in mind. But remember, in an immunocompetent individual, CMV, the body is able to control very easily. So if you're seeing a CMV type infection, okay, please understand, especially, the typhlitis and the terminal ileitis that you can see with CMV. If you're seeing that kind of a thing, look for an immunodeficient state in your patient, okay, that you got, okay? Next slide. Now, you can have a fluid overload. And oftentimes people don't think about fluid overload. When we're transfusing somebody, you don't always think, does this patient have heart failure? So they may have unknown heart failure, And if they do, some of these patients can even have ejection fraction preserved heart failure. So you have to be thoughtful. If they get into heart failure issues, ask the question, what happened? And why are they showing you diastolic dysfunction? Why are they showing you heart failure when you're simply transfusing 1 unit of packed red cells or something? If they go into heart failure, ask the question why, and again, keep thinking, as to what's going on. Next slide. Okay. Let's talk a little bit about anti-thrombotic therapy, and let's go through this. Next slide. Okay. So again, thromboses are where you get clot formation in a specific part of a blood vessel. Okay. This is like intracoronary thrombosis, right? When you have acute coronary syndrome, right? If I clutch my chest, fall to the ground, what do I have? I'm having an intracoronary thrombosis. Okay. It's not that a clot started somewhere else and went somewhere else. Okay. Now, what you will see sometimes is in patients with a cold leg, they'll present with a cold leg. You got a patient in the ICU that's post-acute coronary syndrome. You're managing them, and all of a sudden, the nurse calls you up and says, "Hey, we got the patient so and so. Leg was warm a couple of hours back. Now the leg is ice cold, and the other leg is still warm. What happened? You had emboli, right? Where do emboli originate most commonly? Heart. So in post-MI patients, always remember, if they develop a cold leg or something, this is an embolization, not a thrombotic issue. So you need to get your vascular surgeons involved, get them involved, get them in. You're going to anticoagulate anyway, but the issue for them is they're going to have to go in and take out the clot, especially if the patient is starting to develop a phlegmasia type of situation where the leg is starting to swell. That can get into real trouble. So you're going to have to keep that in mind. Now, when we talk about thromboembolic disease being a major morbidity and mortality, most of the time we're talking about intracoronary thrombosis, acute coronary syndrome, right? So again, keep that in mind. Next slide. Now, when we talk about physical measures, I know we talk about sequential compression devices. We also, the other term for them is intermittent pneumatic compression, right? So you can call it SCDs or IPCs, whatever you want to call it. But understand that in surgical patients, the value of SCDs from a statistical standpoint in prevention of deep venous thrombosis is, according to the most recent American College of Chest Physician guidelines, the yield as far as venous thromboembolism protection, DVT protection, is pretty close to zero in surgical patients. In medical patients, it may be beneficial, but I mean, if you got a patient at risk for bleeding, like a neurosurgical patient, you may not be able to put them on pharmacologic drugs for that. But you got to make note that, for 48 hours, you're going to hold on a neurosurgical patient. And if the, CT or whatever else is okay, and the neurosurgeon says, okay, you can anticoagulate the patient, you're going to give your prophylaxis. So again, think about it that way. Okay. Next slide. Okay. And again, with the sequential compression devices, if you have established thrombosis, we don't like to typically put sequential compression devices on. If you got compromised viability of the leg, you don't want to do that. And again, if you got skin ulcers and stuff, it may be problematic. Next slide. Okay. Graduated compression stockings. I know some of you have thought about this and suggested it. At least some of my residents used to suggest it. They do nothing for VTE prophylaxis. DVT prophylaxis is not helped by that. Now, IVC filter, inferior vena cava filter. If you put an inferior vena cava filter, you can put it from above. No question, okay? You don't necessarily need to put it from below only. But here's the thing. If you put inferior vena cava filter, first thing is it's not the primary treatment for DVT. Please remember that, okay? it's not a primary treatment. Anticoagulation is the primary treatment. Second, okay, if you place an IVC filter, you are running an additional risk of more DVT in the lower leg. Now, your pulmonary embolism risk goes down, but you may develop more clot in the legs, and you may go to phlegmasia issues where the legs start swelling. You may get into that. So keep that in mind. So again, that's something you have to keep in mind. And again, the surgical transvenous embolectomies and the thrombolytics and so forth, we'll talk about a little bit more later. Next slide. Now, remember when we talk about antiplatelet drugs for thrombosis preventions and so forth, and thrombosis treatments, you're talking arterial side. You're not talking venous side, because by the time you detect a clot on the venous side, it's late, okay? The horses have left the proverbial barn, okay? So using antiplatelet drugs to prevent clot formation at that point is really not beneficial. So really, your antiplatelet agents are all for the arterial side. And this is why in acute coronary syndrome, we use antiplatelet drugs all the time, right? So again, very important. In fact, when they do stents, when they do, the newer drug-eluting stents, all have the 2B3A inhibitors that they're eluting, right? So the drug that's coming out of that stent is a 2B3A inhibitor. So it's something that, and the drug-eluting stents are all, game changers. But also remember, if you're on a drug-eluting stent, that patient needs to be on clopidogrel or ticagrelor, needs to be on for at least, anywhere between 6 months to 2 years, okay, depending on which data you're looking at. So if you stop it, be careful about stopping clopidogrel, be careful about stopping ticagrelor, be careful in that setting. Watch what's the indication that the patient's on it. Now, granted, a lot of medical doctors will start clopidogrel and aspirin on a lot of patients just because they feel it makes the doctor feel better. Not a good idea, but that's a lot of the reason why a lot of patients are on it. Now, in that setting, you can stop the clopidogrel. But if it is truly for a drug-eluting stent, if you turn off the clopidogrel, they may thrombose their stent and they may be dead before they get to surgery. So be careful on that front. Next slide. Okay. Cyclooxygenase inhibitors, aspirin, etc. Right? So again, we went through this already. Next slide. Again, aspirin. Low dose aspirin is usually sufficient. 80 milligrams once a day. That's usually sufficient. You don't need to give the big dose aspirin for these patients. Next slide. And the dyspepsia people talk about, we talk about ecosprin. The problem, unfortunately, is it's not due to a physical contact issue. So, the enteric-coated aspirin does not help your patient. They're still going to have the dyspepsia that they would have otherwise. So it's a nice thought, but it doesn't work. So the dyspepsia is there. You may have to give them H2 blockers or something. Next slide. Okay. Clopidogrel, remember, clopidogrel has to be changed by the P450 system in the liver. If the patient's liver is not working for whatever reason, let's say they're cirrhotic, don't use clopidogrel, okay? Please use ticagrelor or prasugrel, the newer ones that do not require processing through the P450 system. So again, please keep that in mind. Next slide. Okay, and ticlopidine we don't use anymore because it takes too long to get to steady state. Next slide. Right. Clopidogrel we already spoke about. Next slide. Okay. The 2B3A inhibitors, we don't give these anymore except when the cardiologists are doing angioplasty without stenting, or if they're doing stenting with bare metal stents. That's rare now. Most of the stents that are being put in now are drug-eluting stents because the patency rates are way better than bare metal stents. So if your patient likely got a stent within the last 2 years, it probably got a drug-eluting stent. And if they got a drug-eluting stent, you got to make sure that they stay on their clopidogrel at least 6 months out, because if they don't, that stent can thrombose. So be careful there, okay? If they end up in your ICU for whatever reason, just check. And here's the thing, Medtronics and yeah, I think Boston Scientific as well, keep a log registry of all stents that are placed. And I know that's a fact in the United States. I don't know whether they keep a log in India or not, but there's definitely a central database that's run by Medtronic. So please keep that in mind. As far as, hold on, let me see that question that somebody had here. Hold on. Where's the chat box? Okay. What can we use for stress ulcer prophylaxis? Okay. Which antiplatelet in GI ulcer patient? You can use clopidogrel. The combination of clopidogrel, aspirin can get you more bleeding, so be careful. And you're not going to use the 2B3A inhibitors anyway, so you don't have to worry about that. Okay, next slide. Okay, keep going. Next slide. Keep going. These are all the 2B3A inhibitors, but you're not going to see them in your ICU unless the cardiologist did a angioplasty only, and that's not that common nowadays. Okay, keep going. Next slide. Okay, dextran. Now your vascular colleague may use dextran. Now dextran is an interesting thing. It's a synthetic polymer. Be careful using excessive amounts of this, because you can throw your patient into heart failure. The other thing about dextran, like any other synthetic polymer, you can get into renal failure. Be careful. Excessive amounts of Hespan, dextran, these have been shown to trigger renal failure in your ICU populations. So if you use excessive amounts, that's trouble. Be careful. We in the 1980s and 1990s, we were using a ton of a polymer called Hespan. Hetastarch is a large starch polymer. And we were using it for fluid resuscitation in the ICU. And unfortunately, or fortunately, some of us were very suspicious of this polymer. And we started doing studies on the toxicity issue. And it turned out that kidney failure was a major toxicity issue with these polymers. So be careful on that front. Okay, next slide. Phosphodiesterase inhibitors, we don't really use these anymore. Dipyridamole used to be used, but it doesn't help that much. Next slide. Some surgeons will religiously put the dipyridamole and stuff on. You have to kind of remind them that it doesn't help the clotting issue, okay? Just kind of be diplomatic, but kind of, say, I don't think it helps. You may not get them to change their practice pattern, but at least you kind of put the facts out there. All right. Anticoagulants. Now, anticoagulants are useful both on the arterial side and the venous side. So when we're talking about anticoagulants, now I'm going to ask you guys, you need to specify if you're putting somebody on DVT treatment or prophylaxis, and you tell me that the patient is on uh, Claxane, enoxaparin, okay? You're going to have to put in your note whether they're on prophylactic dosing, whether they're on therapeutic dosing. What are you covering? Okay. If you're on heparin, unfractionated heparin, are you giving sub-Q, which is prophylactic? Are you giving IV, which is therapeutic? So you need to make sure that there's clarity there. If you're giving IV heparin that is therapeutic, you're going to have a protocol. And most hospitals put in protocols. If you guys want, I can get you a couple of protocols that we have for acute coronary syndrome as well as for DVT, heparin protocols. So if you want, we can get you that. Most places now have switched over to using either low molecular weight heparin or the direct oral anticoagulants, and we'll talk about the DOACs in a second. But so we don't have to measure PTT. So again, very important there. Next slide. Heparin again works through antithrombin 3 mechanism. If the heparin is not working IV, you're going to have to think about antithrombin 3 deficiency, and giving 1 unit of FFP will correct your antithrombin 3 deficiency. So something to think about. Okay, next slide. Remember, please also remember, when you give heparin sub-Q, you're affecting 9A and 10A. So your PTT will not be affected. If you're giving low molecular weight heparin, either prophylactic or therapeutic, you're affecting 9A, 10A. Because you're affecting 9A, 10A, PTT will not be affected. If you're giving Coumadin, your prothrombin time will be affected. PT will be affected, not necessarily PTT. So that's something to keep in mind. So when you're tracking these things, I want you to be thoughtful. If you're giving thrombolytics, TT is the tracking measurement. So think about it that way, okay? And again, with heparin, you need to track and you need to be able to say what you're using. Is it IV? Is it sub-Q? Is it low molecular weight heparin? Is it unfractionated heparin? Tell me what you're using so that, and put it in your documentation so that we know. Next slide. And you can reverse intravenous heparin with protamine. But remember, protamine, there's a problem. The half-life of protamine is shorter than that of heparin. Because it's shorter, you may have to redose the protamine. So if your cardiac surgeon or your orthopedic surgeon, for whatever reason, the patient was on IV heparin, and they say they got too much. So what you need to do is calculate how much they got, when they got it, and then start backtracking as to how much is left. Remember, the half-life of heparin is about 90 minutes. So you're going to work to figure this out. So you need to really start doing the calculation and stuff. So think about that. But you can use protamine sulfate to reverse. Next slide. And again, we spoke about protamine. Next slide. Okay, heparin-induced thrombocytopenia, and I do want to spend a little time here. If you suspect heparin-induced thrombocytopenia, let's say your platelet count is starting to drop and it continues to drop. Remember, the differential diagnosis for heparin-induced thrombocytopenia is sepsis, okay? Your platelet counts can drop related to new sepsis. So keep that in mind, okay? So think about if you suspect sepsis as the reason for your thrombocytopenia, then, you can stop the heparin, yes, but, do you want to start a direct thrombin inhibitor? Maybe, maybe not. You're certainly going to send your antibody test, but if you send the antibody test, here's the problem. The antibody test typically takes about 24 hours to get back, and sometimes longer, depending on your hospital. So the problem here is you got to make a clinical decision. So think about what you have. And if you feel that you have heparin-induced thrombocytopenia, by all means, stop the heparin and give a direct thrombin inhibitor. Now, direct thrombin inhibitors, you can use argatroban. My preference is argatroban. You can use dabigatran, which is also a direct thrombin inhibitor, but dabigatran is not indicated. If you look at the FDA, Food and Drug Administration in the United States, the indication, it's not there for dabigatran. It is there for argatroban. So argatroban is my drug of choice. You can use things off-label. Please understand, as physicians and practitioners, you guys will have the opportunity to use medications off-label. But if you do, please remember this. I don't know how many of you are movie fan. I'm a movie fan. So you notice all these old movies where, you know, it's a war movie and the commander says, I want volunteers for a suicide mission. And, you know, and everybody steps back except for the one guy who's not paying attention and he's left holding the bag. Here's the thing. When you use things off-label, okay, the drug companies are going to cheer you on while you're using things off-label because they're making money. The moment any complication arises and you're using something off-label, the drug companies are going to be the first ones taking a step back and saying, hey, it's not our problem. The doctor was using it off-label. So keep that in mind, okay? So always think, what are the indications? Is the indication there? What should I do? Next slide. So again, the heparin-induced antibodies bind to platelets and the coagulation system gets activated inappropriately so. Next slide. Okay, the treatment, stop the heparin, and again, direct thrombin inhibitor. You cannot give Coumadin. Do not give Coumadin in that setting, okay? And when is it safe to think about giving other issues as far as anticoagulants go? Once the platelet counts comes back over 100,000, 1 lakh. It has to come back over 1 lakh. Once it does that, then you're safe, okay? At that point, I would not use heparin. We have so many other alternatives now. You can use the direct oral anticoagulants. You can use other things. You don't need to just go with heparin at that point, okay? Although the probability that claxane or low molecular weight heparin will cause heparin-induced thrombocytopenia is fairly low. The probability is less than 5%. But again, no need. You can use something else. Next slide. We can use Huridin, Luperidin. So again, you have other options. Next slide. Okay. When we talk about low molecular weight heparin, we're talking about, you know, something that's going to take out factor 10A and 9A. So you can use this in established DVT. When you have established deep venous thrombosis or pulmonary embolism, you can use this and you can give, the dosing is a little higher. It's 1 milligram per kilogram actual weight, okay? Remember, in obese patients, it's actual weight, okay? In non-obese patients, it's also pretty much actual weight. So really speaking, you want to use the actual weight, not ideal body weight. You know, people like to say, oh, this patient is, 5'8", therefore the ideal body. No, use actual weight. That way you're not underdosing. It's very important. Now, if they have kidney dysfunction, obviously you got to think about it. Again, renal issues are a problem. Now, here's the other thing, okay? When we get to the direct oral anticoagulants, apixaban, Eliquis is the trade name here, but I think apixaban is the name in India. Apixaban can be used in patients with acute kidney injury or chronic kidney issues and not have a problem. You can use it all the way up to dialysis. So you can use some of the direct oral anticoagulants. You cannot use rivaroxaban. You cannot use dabigatran, you get too much bleeding. Rivaroxaban, you get bleeding, and that's a problem. So that's something to keep in mind. Okay, the recent studies on apixaban seem to show an advantage there. So again, something to keep in mind. Here's the other thing about anticoagulants. The studies that were done in the 1990s and 2000 and all that showed the biggest population at risk for bleeding complications related to anticoagulants is the chronic kidney injury or the acute kidney injury patients. So keep an eye out. If your serum creatinine is like 1.5, 2, that range, that patient may be at higher risk than the general population for bleeding complications if you give a subcutaneous heparin or IV heparin. This patient may develop bleeding complications. So keep that in mind, okay? So that's something to think about. Next slide. Okay. Direct thrombin inhibitors we already spoke about. Next slide. Remember, if you have to reverse direct thrombin inhibitors, it's very challenging because the problem is the prothrombin complexes or the fresh frozen plasma will not correct the problem. So you cannot get to that. So you have to think along those lines and be very careful. You may have to dialyze these patients to clear that anticoagulant that's there. So keep that in mind, okay? Next slide. Okay, the newer oral anticoagulants, dabigatran, it's a 2A inhibitor, the direct thrombin inhibitor. You have to use the Pradaxbind, which is a reversal agent for dabigatran. Apixaban and dabigatran, that reversal agent actually just came about over the last, I think, 2-3 years. Before that, dabigatran was being used. Unfortunately, we actually had a patient with a subdural hematoma that was on dabigatran. We did not have the reversal agent at that time. And we literally watched the patient bleed out and die because we could not reverse it. There was nothing to do. We tried dialysis even. But, you know, dabigatran is a real problem. Now with Pradaxbind, it's actually okay. We can reverse it. So it's something to think about. Apixaban, rivaroxaban, and doxaban are all the newer oral anticoagulants. Next slide. Okay. Dabigatran, the reversal agent is idaruzumab. You need to know that because that's the Pradaxbind is the trade name, but the generic is that. Next slide. Okay, you can use andexanet alpha for reversal of rivaroxaban, apixaban, and oxaban. But the thing is that please remember, the andexanet alpha is very expensive. Prothrombin complexes typically are cheaper. So you may want to use prothrombin complexes. They both work equally well. So that's something to keep in mind. And more of our patients are on the direct thrombin inhibitors. Now, to cardiologists, it's a godsend. To the trauma physician, patients, people who take care of road traffic accidents, it's a nightmare. Take your pick on which side you sit on. It's definitely an issue. Okay. Next slide. Next. I think we'll pull up here. Any questions? You guys have seen pretty much all of coagulation and hemostasis issues. Yeah, Sanat.
The evidence for mechanical thromboprophylaxis is mainly in surgical rather than medical. I think you told the other way around.
Yeah, well, I mean, again, in medical patients that have severe systemic inflammation, you do want to give DVT prophylaxis in that setting. So again, the percentage of patients that don't get the appropriate prophylaxis, actually the study was done and people looked at what percentage? About 40% of patients that are medical patients that require prophylaxis. If you look at the risk scoring, and remember, the risk scoring really has one of the bigger components is age. So if you're dealing with somebody over age 65, that patient is at higher risk for developing DVT. Those patients need to be prophylaxed. And unfortunately, because we don't think about the inflammatory state causing this situation, it's something that we really need to pay attention. My suggestion always is do a risk assessment. It's fairly easy to do. And you can pick whatever score you want. If you Google risk scoring system for DVT, there are many scores that are out there, but they're fairly straightforward, and it's fairly easy to see which patient requires it. And at that point, put them on DVT prophylaxis. Now, does the DVT prophylaxis protect your patient 100%? No. Remember, there's about a 30% failure rate, even in surgical patients. There's about a 30% failure rate, even if you prophylax them properly. Okay. So you have to keep watching these patients for development of DVT. Now, remember also that DVT develops in the calf and not in the calf veins, it's symptomatic. The asymptomatic DVT is what concerns me, because those develop in the upper thigh and the pelvic veins. Those can give you pulmonary emboli. That can kill a patient. The calf vein thromboses won't kill your patient. They may cause you, they may be unsightly, they may be other problems, but they're not going to kill your patient. What will kill your patient is the thrombus that's sitting in your femoral vein. That is the problem. So we have to keep that in mind. Any chance we can get this? Of course you can. We'll forward them to you. No problem. Any other question? Yeah.
I have one question, Dr. Chandrasekhar. Look,
Sure.
very frequently we do talk about giving platelets with a number, and functional platelet assessment is such a difficult point of care assessment, which is not a very common availability. Nor is the other things about TEGs and other thing. It's not a commonly available thing. I'm just wondering, when we are doing procedures, if not for major surgical, neurosurgical, or other procedures, is there any time limit when the platelets are given and then done? Because sometimes procedures become very urgent.
Yeah,
and
usually with platelets being given, let's say you're putting in a central line and the patient, is on an antiplatelet drug like ticagrelor, okay, or Brilinta. So if you just start the platelet transfusion, you can do your procedure. It's not an issue because it enters the circulation and the platelets are working at that point. If your platelet count is above 50,000 for central lines, you can green light it. It's not a problem. I know people like to talk about saying, well, if you're going to do a subclavian, you don't want to do a subclavian because you cannot compress it. Listen, all that, if you really look carefully at the data, there is no issue. Okay. You don't get into any trouble. Just need to make sure that you're careful when you're putting in the line. And if you got somebody who's experienced at putting in lines, they can put it in anywhere. It's not a problem.
I mean, say, central lines and sciatic tap chest drains are anyway though, so it ends up being double-edged sword. If you do it, you may cause harm. If you don't do it, you may cause harm if there's a hemothorax, for example.
Well, I think if you need a central line, you go ahead and put it in. And if you think you need platelets, give a unit. That's fine. Run the unit while you're getting ready to start, as you're prepping the patient. Run the unit in. Once the unit is in, as the unit is going in, you can start doing your procedure. It's not a problem.
And the other question I had was about whole blood transfusion. Not uncommon in the Western world and not infrequent in a country like India. So I'm just wondering, look, how much necessity is it when we start giving whole blood transfusions, or when it is given about the other products and yeah,
Actually, if
or,
you're
or
giving whole, yeah, if you're giving whole blood, I would say you don't need to give the other products because it's all there. The 1 to 1 ratio of FFP to platelets to packed red blood cells is because we use component therapy. It is not, if you're giving whole blood, you don't need to give anything else. Just give whole blood. The issue is if you're giving component therapy, if you can give FFP and platelets, the amount of packed red cells that you're going to need for transfusion goes down. That's why we give it as that. But if you can get whole blood, God bless. For trauma, the best thing you can give is whole blood, no question. So from that perspective, no question about it. Let's see, what was the for regional blocks on anticoagulant, can we give platelet? Okay, if there are no low molecular weight heparin, let's say epidural, the anesthesiologist that's giving the epidural is going to be very squeamish to begin with, because they're not. And in this setting, you're going to have to give fresh frozen plasma, not platelets. Remember, low molecular weight heparin is an anticoagulant, not an antiplatelet drug. So if they're on low molecular weight heparin and you want to do an epidural, you may have to give them fresh frozen plasma, in which case you have to give at least 1 to 2 units of fresh frozen to make the correction that you need. 1 to 2 units usually is sufficient for that correction. But, if the anesthesiologist is squeamish, then you may not be able to do that. Sana?
Yeah, I mean, giving FFP for LMWH or whatever anti-coagulation they're on, but unfortunately, the anesthesia guidelines don't support that. So that is the reason we are usually scared to go ahead with it. I mean,
Yeah,
yeah,
I
practically
mean,
probably it might not be significant, but there's no guidelines to support if anything goes wrong.
yeah. Actually, there's a couple of studies that have looked at hip fracture patients, where the low molecular weight heparin was on already preoperatively, and the anesthesiologist that had the I don't know if you want to call it guts, but they they put in epidurals. There was no complications that were seen, but the issue is that again, I think listen, if I was an anesthesiologist and I was doing epidurals, I would be worried. So I would say, put them under general anesthesia and go for it.
Dr. Chandrasekhar.
Yes, ma'am.
Good morning. My name is Varna. I'm a nephrologist. I have
Yes, ma'am.
a question for you.
Yes.
This is with regards to, I say this more in Western world than here. I see patients who've been on warfarin, more so elderly, who for atrial fibrillation. We swap them to have comes in with hip fractures. We swap them to full dose of Clexane.
Yes.
1 milligram per kg body weight twice daily.
Yes.
And in renal patients, it's guided by, I mean, as you know, there's not particular thing. We just give once daily. So now the question is, sometimes the surgeries and most surgeons ask us to hold at least 2 doses before the procedure. Clexane. Is there any evidence for that?
And their own data would suggest that they don't get any extra bleeding, and that the thrombosis risk is way greater than the bleeding risk. But the problem, unfortunately, is the orthopedic surgeons, like neurosurgeons, are creatures of habit. And when they're creatures of habit, trying to convince them to change their methodology becomes very challenging. But you can have a discussion. My approach on all these is, listen, it doesn't hurt to sit down with the orthopedic surgeon or the neurosurgeon. and have a cup of tea and say, listen, your own literature doesn't support holding anything. So can we please not hold it? Um, you know, First few times they do it, you have to hold their hand through the procedure. After that, they get comfortable, then they don't mind. So it's a matter of kind of working through it. I agree with you. You're absolutely right. It's it's ancient medicine, but it's something that we as intensivists see. We wear different hats. When I'm the primary, I can dictate to somebody. But when an orthopedist is going to do a procedure, you have to kind of be diplomatic in that sense and say, let's go have a cup of tea and sit down and try to convince them that way. Um, that's all I can tell you.
Thank you, Doc.
Sure. Any other questions? Okay.
That was great. Thank you very much, Dr. Chandrasekhar.
Perfect. And like I said, I think for the next one, we'll talk about one of the other topics, probably damage control. I do want to go over damage control because we've had a couple of cases where we've had the acidosis, coagulopathy, hypothermia. How do we manage it? How do we get through it? So I think probably for this coming Tuesday morning, we'll cover damage control.
Great. Thank you.
Okay.
That'll be fantastic. Thank you, everyone, for joining. And please expect the paper for coagulation questions this afternoon, all of you.
Perfect. Okay. Thanks, Shashi.
Thank you.
Nagavinik, you can stop recording, please.